Hey folks, and welcome to our video on sexually transmitted and genital infections. And it is worth noting that those are two separate concepts, although many diseases fulfill both criteria. So there are some diseases we're going to talk about today, like HIV, which are sexually transmitted but don't really cause a focal disease around the genitals, and whereas there are some like Candida that are not sexually transmitted but can cause a genital infection. Okay. So here's an overview of the things I'm going to look at. I will apologize in advance. This is a pretty wordy document with not too many pictures. Sometimes they show you basically like what it looks like. The reason I haven't included those is mostly because they're pretty hard to distinguish, and you're not usually asked to distinguish them by appearance. What you are sometimes expected to know is the appearance of the organisms themselves. So we included a couple of those. But actually, knowing what the rash looks like is not really particularly important to you guys, especially as you're not going to be doing any examinations of genitals yourselves as medical students in year two. But these are basically the organisms we're going to look at. So there are three bacteria that we are particularly concerned about, although they're not the only ones. We've got a couple of viruses and then a protozoan and a fungus to round us out. Let's talk about chlamydia first. So this one is notable because it's what we call an obligate intracellular bacteria. So it has to invade cells and reproduce within cells in order to survive. The reason why we don't have morphology there is because it actually has two forms. So it has a infective form, pathogenic form, whatever you want to call it, which is the thing that actually infects cells, and it also has a replicative form. So when a pathogenic form encounters a cell, it can infect it, gain entry, and it then produces a whole bunch of replicative forms. And only then, once matured, the population has grown a little bit, it actually produces a whole bunch more pathogenic forms and then moves on. And it moves on by inducing lysis of the cell, breaking the cell open in order to release all of those bacteria. And that's actually what causes the actual disease. So in terms of our transmission, we have two that are going to become pretty common over the course of this little presentation, which are sexual contact, obviously, for STDs, and also mother to infant child transmission. So this is also sometimes called vertical transmission. It basically means a pregnant mother with the disease can pass it on to the baby, usually during delivery. And so that lends itself to two, pretty parallel forms of prevention. So safe sex practices, and also, in many cases, elective cesarean sections, because in a lot of cases, the place the transmission actually takes place isn't in utero, although that can happen. It's much rarer. It's much more common to have these happen during the delivery itself. So somewhere in the birth canal. And so one of the prevention strategies we can use for babies is to undergo a C-section. We've got the incubation period there. That's only really relevant for history taking, so be aware of it, but obviously it's not that important. And really, one of the biggest things that I want you guys to take away from this one is that it is commonly found with gonorrhea, so people can have both gonorrhea and chlamydia, and it has somewhat similar symptoms to gonorrhea. So clinically, because these have quite a wide range of symptoms and they overlap, you can't really differentiate chlamydia and gonorrhea for sure. And that's why we want to really look at those PCR and those swabs and microscopy when needed to actually figure out which organism is responsible. Because otherwise we're sort of taking stabs in the dark, and the treatment is a little bit different between the two. So we get we can get asymptomatic cases with these, which is also the case with a lot of STDs. Unfortunately, although females are more likely to be asymptomatic, there are some suggestions that this leads to a higher rate of complication because it doesn't get caught earlier. And then we end up with a whole bunch of different inflammatory, primarily, complications that happen in females and rarely in males. And then, like again, most of these STDs, we get a lot of very nasty complications if they happen in a neonatal case. So we really want to avoid that if possible. Since it's a bacteria, we just treat it with antibiotics. And here's Neisseria gonorrhea. So this time we actually do have an image because it has a pretty consistent morphology. It's a gram-negative intracellular diplococci. So cocci are little balls, and diplo, there are two of them. And you can see that it's coated in all those pili. And those are actually going to be quite useful to it and quite relevant to how it actually does its work, because it uses them to actually attach to mucosa in certain areas and to enter non-ciliated epithelial cells. So most of the mucosa that it encounters has cilia. When it finds a cell that does not have cilia, it invades those and uses those to get through the basement membrane into the host. Usually the symptoms you get from this are not from the bacteria themselves. They cause some cellular damage, but not a huge amount. Instead, it's usually your own inflammatory response that causes it. So again, we get entry via basically things that might be that might come into contact during sexual intercourse, and also mother to infant child transmission. So you can see again those symptoms are really quite similar to those of chlamydia, and so it's quite difficult to differentiate between the two. And unfortunately, again, complications are more common in females. In this one, there's a higher risk of blood infections. So chlamydia doesn't usually cause quite the same issues there. They tend to be more localized. Here, we can get a lot of issues with, obviously, if it's in the blood, it can go pretty much anywhere. So it can go to the bones, you get septic arthritis, you can go to the skin, you get rash, you can go to your heart, and you get endocarditis. And so those can all be quite a big problem. We can get ophthalmia neonatorum in neonatal cases. Bit of a pattern here. There's a lot of eye sequelae that tend to happen in neonatal cases. Again, we get a diagnosis via PCR and microscopy culture and staining, and we manage it using antibiotics. Okay, let's talk about syphilis. So this one is quite an interesting morphology compared to some of the other ones. It's a gram-negative spirochete. You can see actually a whole bunch of them looped together. A single one of these is just going to look like a little sort of curve, almost like a 2-minute noodle before you cook them. And so it has a quite distinctive shape, which makes it pretty easy to identify under microscopy, which is quite useful to us. So this can again be spread through standard sexual contact and mother to infant child transmission. I will raise the point that in this one particularly, we're really worried about what we call the syphilitic chancre, or I don't know if I'm pronouncing that right, but that word, which are basically the ulcers that it causes. So in the first stage of syphilis of 3, so the primary syphilis, we get those in the genital regions. And so obviously that causes quite a high risk of sexual transmission. But then we also get a rash in secondary syphilis, which can happen much later. And that's also highly infectious. So in all of those cases, you really want to make sure that you're limiting contact between infected people and non-infected people, because it can be quite a big risk. And just to elaborate on those stages a little bit, so your primary syphilis, that's your initial infection. So it's until then we are basically asymptomatic. Then the secondary stage is when it basically goes from a local infection to a systemic infection. And then tertiary, that's a really, really long-term sort of thing. And so you can get sort of disfigurement as a result of granulomas, as well as all sorts of different things. And one of the big ones is neurosyphilis, which is partially why syphilis is a potential differential for things like psychosis and confusion, because somebody might have tertiary syphilis, which has now got into their nervous system, basically. Quite a dangerous one also for babies. It's quite bad. And so we try to treat it with high-dose penicillin when we can. Another quick note in this one, that even though I've said there the primary syphilis tends to happen in the genital regions, it doesn't always happen in genital regions. So there's maybe like a 5 to 10% chance that you get them in other places, usually other places with similar sort of epithelium, so your fingers, your lips, or nipples. And also important to note that it's a notifiable disease, which also goes for gonorrhea, actually. And so you would want to notify the Department of Health and engage in contact tracing with the patient and any people that they've come into contact with. I think, as far as I remember, we're currently in an epidemic of syphilis in Victoria, so one to watch out for. Okay, let's talk about viruses. So, herpes simplex virus. So, the ones that we're particularly concerned about are HSV1 and HSV2. There are quite a lot of herpes viruses, and they all do different things, but today we're going to be looking at these two, which are broadly form what we call genital herpes. And so historically, it's been sort of suggested that HSV1 is the oral one and HSV2 is the genital one, but in practice, maybe, basically. So we can get a bit of crossover in symptoms, which makes it a bit harder to say that they're definitively one or the other. But HSV1 is much more common. So this is the one, if you've ever heard, like, everyone has herpes. what they're trying to say is everyone has HSV1. And so, it's true to an extent. Maybe, 7 out of 10 people have some level of HSV antigens, antibodies sorry, not antigens, antibodies. They specifically have HSV in them somewhere. So it's not just that they have immunity, it's that they have latent virus in them. And HSV2, not quite as common, but still important, obviously. So in terms of how they spread, HSV1, again, it's almost easy if you remember the oral link. So it's salivary transmission. In HSV2, usually sexual contact. And in both of those cases, we can get, again, MICT through the birth canal. And so, again, management is going to be pretty straightforwardly linked to those modes of transmission. Sorry, that's prevention, not management. And so the big thing with herpes viruses is that they stick around. There's a little rhyming mnemonic, Herpes Viruses never go away, which is basically just to say that all of these guys like to stick around. That goes for some of the other human herpes viruses, so stuff like cytomegalovirus. Those also like to hang around somewhere in your body and then reactivate way later on to cause an infection, or if you become immunosuppressed, to cause an opportunistic infection. So with HSV in particular, we get a primary infection when we actually initially show up, and then we can get a recurrent infection because the virus has gone to the dorsal root ganglion. It's hung out there for a long time, pretty much doing nothing, and then it comes back as a secondary infection. Now, that is actually quite important to be able to differentiate on your investigation, your examination, your history, whatnot. And really the biggest tell is that the primary lesions, they're sort of a bit less organized because there'll be a period of exposure, different time to actually develop symptoms. And so the lesions that you see, there'll be at lots of different stages. Whereas if you get a recurrent lesion, it'll all have come down at once from the dorsal root ganglion usually. And that means that they'll all be in a fairly localized group, and they'll usually be at the same stage. And so from a careful examination and given a good case, basically, you have a good chance of figuring out if somebody is primary or secondary. And of course, the history is important there, because if they've had herpes before, it's probably secondary herpes. Yeah. And so that, unfortunately, recurrence rate is quite high, so you do need to keep an eye out for that. And again, neonatal cases involve bad things. This one we treat, obviously, not a bacteria. We don't treat it with antibiotics. We treat it with antivirals instead, and we diagnose it via PCR. Okay, HPV, this is one that you may have been part of a societal prevention strategy for, because you guys probably got the Gardasil vaccine. This was initially given to only girls, and then because it was basically is much higher risk in women than men, particularly because it has such a big risk with cervical cancer. And then somebody had the bright idea, well, if we also vaccinate men, then we'll be able to halve the transmission even further. And then they decided to do that, and the rates dropped even more significantly. So go figure. But in terms of the actual structure and the pathogenesis, so it's spread through skin-to-skin contact, which can include sexual contact, obviously. And it sticks around for a while, can then cause a infection of genital warts, and that can be linked to higher risk in all sorts of cancer, specifically, like I said, high risk in cervical cancer. It's diagnosed via the pap smear test, and again, now we're trying to give vaccines to everyone, and so the prevalence of this has actually dropped quite a lot, as well as the prevalence of cervical cancer. So it's a bit of a success story, this one. And yeah, again, with the pathogenesis, so the reason that it actually causes an issue with cancer is that it integrates into your genome. So almost any virus that integrates something into your genome is going to have a cancer risk, because it is involving basically unchecked alteration of your genes, and that includes the potential to cause damage or changes or mutations. Okay, big one, HIV. So you might already know that HIV is an RNA retrovirus, so it carries its genetic information as RNA, and then it converts it to DNA using reverse transcriptase and uses integrase to put that into your host genome. And so, like we said just before, it also carries a cancer risk, but that's not the main issue. because it does something rather important, which is that it reproduces in what you would call your CD4 cells. And that just means that they have a certain receptor called CD4. And unfortunately for people with HIV, it involves T helper cells, monocytes, dendritic cells, and microglia. Of course, the most important of those are T helper cells, because they're pretty much central to your immunity. If you think back to the whole immune pathways, they're both central to cell-mediated immunity and necessary in order to get humoral immunity. So if you knock out enough of your TH cells, then basically you're not going to have any adaptive immunity left, and that causes a lot of problems. And so we initially have an acute phase where you're basically just fighting off a viral infection, and so you have pretty typical viral infection symptoms, and then later on, it sort of hangs around in your CD4 cells. Obviously, your immune system can't target the virus inside those CD4 cells, and so it slowly reproduces, slowly infects more CD4 cells, and your CD4 cells slowly drop over time. And so if you actually look at this is a graph that you'll see over and over again in reference to HIV, because they love it, because it pretty much sums up the idea involved. So you have your primary infection, again, your non-specific viral illness, and then it looks like everything's fine for a moment. Your CD4 is back up at least a little bit, and your virus is back down. But then over a long, long time, it slowly creeps up, and this can be quite variable. For some people, we get basically AIDS, the syndrome itself, within 2 years maybe. Some people it takes, like here, 7 years or something. Some people never get AIDS. So some people are called elite controllers, and they basically just have HIV, but it never gets to the point where they have enough viral load to either become infectious or to have AIDS and to get opportunistic infections. But that's the basic idea. So the typical course is that we then slowly decline in CD4 cells, and then there's a bit of a tolerance, but at a certain threshold, you just don't have enough cells. And so you start to get lots of opportunistic infections, as all of those really weak pathogens that are usually fought off by the immune system suddenly see their chance, and they start causing problems. And so the presentation in the chronic phase, which is the one associated with AIDS, the most important one, is basically all of these little infections that would usually be pretty easy for the immune system to overcome, but now are an issue. Kaposi sarcoma is not an infection, that's a cancer that is associated with it. And so in Western countries, okay, that's not fair, in developed countries, it's typically associated with men who have sex with men. That's not really an inherent quality of the disease. There is a high risk of transmission in what we call receptive anal intercourse, and that's because it causes what we call microtears, which involve more exchange of bodily fluids in the form of blood. But if you look at countries where this is actually endemic and rather epidemic, mainly in Africa, sub-Saharan Africa, we see that we actually get pretty high rates in both males and females. And so we can't think of it really globally as a disease among men who have sex with men. It's a problem with all sorts of people, can be transmitted by all sorts of people, including mother to infant child transmission, of course. And so it causes problems for everyone. In terms of treatment, we basically look at antiretrovirals. So these are things that specifically target the ability of HIV-1 and HIV-2 to turn that RNA into DNA that it can then integrate into the genome. And we have a lot of different therapies there, including CAR therapy, just means combination antiretroviral therapy. And so it's just combining different drugs that we know work into a more strong therapy. All right, we're now getting into some miscellaneous organisms. So first of all, we have Trichomonas vaginalis, which is a protozoan. You don't really need to know anywhere near as much about these as you needed to know about our previous pathogens. Really the important things to understand here are that you get a smelly, frothy, or malodorous, if you want to be a bit more clinical, frothy vaginal or penile discharge and itchiness, and in females sometimes cervicitis. We can diagnose it using PCR, which is, again, usually as a blanket rule, PCR is probably going to be the most effective tool, and then you can do MC and S if needed. I think I forgot to mention, you can't actually culture syphilis because it just is so bad at surviving outside humans. Gonorrhea is also quite bad at surviving outside humans, but it's okay enough that you can culture it. Syphilis, you just cannot culture it at all, and so you have to do only microscopy and scanning. With something like this, you also want to probably stick to microscopy just because it's a bit harder to culture protozoa than bacteria. But for something like chlamydia, you just go straight to the culture. But that's always going to be a bit slower and less efficient, but it's also cheaper than PCR. We treat it with metronidazole, which you might also recognize we use for amoebiasis. So it's a pretty good anti-protozoan tool. All right, and then Candidiasis. So Candida albicans, you might have remember something like oral thrush that we would have talked about a while ago in terms of a respiratory tract infection. So it's a fungus. It causes these little sort of white depositions. In terms of genital infection, that shows up as what we describe as a cheesy discharge. Caseous, I think, is the more clinical term. And so it's pretty similar to UTI. Just because discharge is a potential symptom doesn't mean it shows up all the time or it's easy to see. And so a lot of patients will come in and it'll basically look like a UTI. And so that's why you really want to make sure you're testing the swabs and the samples and making sure that it's not just a normal UTI. You don't treat it like that. And again, this one is pretty much present in everyone. So it's not a sexually transmitted disease, really. It's a genital infection. And it is most important when we have somebody like an AIDS patient who's immunosuppressed, or we've artificially immunosuppressed them. And that means that basically their immune system is no longer able to fight it off. We get overgrowth, and it becomes a problem, basically. And so this time we use antifungals against it. Fluconazole, very important, of course, that we don't use UTI drugs against it because those are all antibacterials, and they will do approximately nothing against candidiasis.